This is Randall Schell, and I'm making a podcast entitled High Yield Subspecialty Review Cardiac Keyword Topics, and this is part 3 of a 3-part series. As a reminder, it is the cardiac keywords from 2006 to 2015 that we are covering. These are the cardiac keywords from 2015, with B indicating those that were part of the basic exam, A for the advanced exam, and GAP 2015 being the cardiac keywords of which CA3 residents missed frequently. Let's go to our first topic, which is cardiac changes with obesity. With excessive adipose accumulation, it is not uncommon to have associated sleep apnea or obesity hypoventilation syndrome. These patients can have hypoxia and acidosis that result in pulmonary arterial hypertension, and that pulmonary arterial hypertension can result in right ventricular hypertrophy and enlargement as it pumps against that resistance. And that is shown on this pathway here to RV hypertrophy and enlargement, one of the problems with obesity. On the other side of this graphic, it shows the excessive adipose accumulation resulting in increased circulating blood volume, more blood going to all this extra fat tissue. The left ventricle has to work more. There has to be an increase in cardiac output with little change in heart rate. As the increase in cardiac output is required, the right ventricle can hypertrophy and enlarge, and the combination of pulmonary arterial hypertension and increased flow can result in RV failure. The LV can enlarge, the wall stress can go up, it can hypertrophy, and if inadequate hypertrophy, you can have LV systolic dysfunction with a low ejection fraction. You can have also LV diastolic dysfunction with high LV EDP and poor relaxation issue, both contributing to LV failure. So biventricular failure can occur secondary to obesity. These are some of the cardiac changes. Please note that initially, at least, systemic vascular resistance in many studies have been shown to decrease, that is in normotensive obese patients, and there's little change in heart rate, but there is an increase in cardiac output. Next topic is pulmonary hypertension. By definition, that's a mean pulmonary artery pressure greater than 25 millimeters of mercury at rest. We previously have calculated pulmonary vascular resistance as a change in pressure over a flow, and the change in pressure is mean pulmonary artery pressure minus the pulmonary arterial occlusion pressure over cardiac output times 80. The estimation of the pulmonary artery pressure can be done using echocardiography. And the top right graphic shows the right ventricle in the right atrium with color flow Doppler, as well as a CW Doppler picture across the tricuspid valve showing the jet velocity. And this jet velocity correlates with the pressure in the RV systolic pressure and pulmonary artery systolic pressure. And the higher the velocity, the higher the pressure. Because if the pulmonary artery pressures are high, the RV pressures are high, assuming no pulmonary valve problems. And during systole, if the RV pressures are high, you can imagine the gradient from the RV to the right atrium across the tricuspid valve, and TR, which is present in 80 or 90% of us normally, will go up in velocity because of that pressure gradient. Very high velocity is associated with pulmonary artery hypertension. In fact, 4 times the velocity squared plus the CVP is one way to estimate RV systolic pressure, i.e., if that jet velocity happened to be 3 meters per second, that would be velocity squared, 3 squared is 9, times 4 is 36, and let's assume CVP was 10. That would mean that RV systolic pressure was approximately 46 to 50 range. Etiology of pulmonary hypertension is diseases such as chronic obstructive pulmonary disease with destruction of alveolar capillary units, mitral valve disease like mitral stenosis and severe mitral regurgitation, chronic hypoxemia with constriction of the pulmonary vasculature, left heart failure with fluids backing up into the pulmonary system, obesity hypoventilation syndrome with chronic hypoxemia and retention of CO2, Congenital heart disease, many types can do this, and then idiopathic. On electrocardiogram, you may see P pulmonale, peaked P wave, and lead 2, and you may see RVH as well as right bundle branch block as there's changes in the right ventricle from the pulmonary hypertension. And on echo, the atria can enlarge as well as the ventricle on the right side can dilate as well as hypertrophy, and as previously mentioned, that jet of tricuspid regurgitation, the velocity of it can be used as an estimate of RV systolic pressure. The treatment for pulmonary hypertension is correct hypoxemia by administering oxygen, vasodilators such as calcium channel blockers and phosphodiesterase inhibitors such as Viagra or sildenafil. Sildenafil, if a patient's on that, you need to avoid concomitant use of nitrates because of the risk of hypotension. If sildenafil is being used in a patient for pulmonary hypertension and they're coming for surgery, it's not good to stop that before surgery, but continue it. If a patient is on sildenafil for erectile dysfunction, realize that the half-life is 4 to 5 hours, and you should probably stop at 3 half-lives or so more before surgery. Inhaled nitric oxide, because it goes into the alveolar unit, crosses the alveolar unit, dilates the alveolar capillaries, binds to hemoglobin, and then does not have a systemic vasodilating effect, as well as prostacyclins are all used in the treatment of pulmonary hypertension. We want to avoid anything that increases pulmonary vascular resistance or causes vasoconstriction of the pulmonary artery. Increases in CO2, low oxygen levels, acidosis, getting cold, sympathetic stimulation with release of norepinephrine, all can result in increases in pulmonary vascular resistance. Of our anesthetics, ketamine and nitrous oxide can increase systemic vascular resistance as well as pulmonary vascular resistance, increase sympathetic stimulation, and may be avoided in patients with pulmonary hypertension. The next topic is pulmonary embolism. And embolization of the pulmonary artery can occur due to air, for example, craniosynostosis surgery, C-sections, prostatectomy with a head down position, amniotic fluid in the case of pregnancy, delivery, and precipitous delivery, blood clots, thromboemboli, tumors, fat emboli, for example, liposuction. And the signs and symptoms in an awake patient differ from what we see intraoperatively. In an awake patient, dyspnea, tachypnea, pleuritic chest pain, and a drop in SpO2, but intraoperatively it's common to see hypotension if it's big enough to block blood flow out the pulmonary artery to any great extent, hypoxemia, and bronchospasm. And frequently we see a big drop in end-tidal CO2 when a significant embolization occurs because of an increase in arterial to end-tidal CO2 gradient or dead space. And it's not uncommon to have an end-tidal CO2 of 35, for example, and then the embolism occur and it drop into the mid-teen range suddenly. There can be an increase in RV systolic pressure as the right ventricle is trying to pump out against an obstructed pulmonary circulation. The CVP can go up, the tricuspid regurgitant jet velocity will go up as RV systolic pressure goes up, and the RV can fail. The picture on the top right simply shows how an embolus can come in through, in this case, the infravena cava into the right atrium, cross over, and if there is interatrial septal communication, could be a paradoxical embolization to the left side, and otherwise usually goes into the right ventricle, into the pulmonary artery, and then goes out into the pulmonary vasculature. A diagnosis can be made by echo, looking at the RV. Oftentimes you do not see the clot itself, but the effects of the clot, which is a dilated right ventricle, as shown in the figure on the right, as well as increasing tricuspid regurgitation in an underfilled hypovolemic left ventricle. Arterial blood gas can demonstrate the hypoxemia, as well as support the PaCO2 end-tidal CO2 gradient, and D-dimers will go up as fibrinolysis is occurring, and a CT angio can be a diagnostic tool. Next topic is cardiac tamponade. What does it look like on echo? On the top right is a picture of fluid, represented by the asterisk, surrounding the right ventricle and right atrium. Cardiac tamponade, or fluid around the heart, causing tamponade physiology or obstruction of diastolic filling, results in decreased stroke volume, cardiac output, and blood pressure. And classically, it causes diastolic equalization of pressures. That big bag of fluid, if it's all around the heart, the pressures during diastole, both the CVP, the pulmonary diastolic pressure, as well as the wedge pressure, which is an estimate of LV and diastolic pressure, all become very equal. And for example, they might all be reading approximately 20. Beck's triad is the clinical signs of cardiac tamponade of hypotension, jugular venous distension, and you can barely hear the heart sounds because the heart is in a bag of fluid. Occasionally, you can see electrical alternans as the heart is sitting in a bag of fluid, rotating back and forth in that fluid, creating different vectors, and your EKG can look very bizarre. Kussmaul's sign is when you take a breath in, and I like to think of the lungs inflating around that bag of fluid and compressing it, and JVD occurs. Pulsus paradoxicus, when you take a breath in, you're impeding filling of the heart even more, and there's a drop in blood pressure of greater than 10 millimeters of mercury with inspiration, pulsus paradoxicus. You can diagnose this on echo, but chest x-ray is not very sensitive. It takes quite a bit of fluid to do so. If fluid accumulates slowly over time, you can have a large amount of fluid in the pericardium, while acutely the heart cannot tolerate very much volume without causing tamponade physiology. Our treatment is to keep the patient fast, full, tight, and hard, meaning fast, tachycardia, full, preload up, tight, maintaining SVR and contractility up. We want to avoid high peak airway pressures because they will raise the pressure in the lungs around the bag of fluid that's surrounding the heart and worsen filling of the ventricle. And so negative pressure breathing, avoiding positive pressure breathing can be helpful. Avoid decreases in systemic vascular resistance. Maintain contractility. Ketamine has some benefits of maintaining SVR and keeping the heart rate up. And if you're really in deep straits and problems, think about local subxiphoid pericardiocentesis. That is, local anesthesia, subxiphoid, do a pericardiocentesis, remove some of the fluid before you induce general anesthesia, or even cardiopulmonary bypass with support via the femoral vessels prior to induction. Pressure volume curves pathology is the next topic, and we will look at different valvular lesions and their effect on the pressure volume curves. Up at the top right shows pressure volume curves on the y-axis, left ventricular pressure, on the x-axis, LV volume. A is a normal pressure volume curve, and if you go back to an earlier podcast where we went through the points on the pressure volume curve and what they mean, that may be useful to you. But let's look at patterns for right now. In the case of C, first, notice that the inside of the left ventricle is generating extremely high pressures inside there, and that would be the case of, for example, aortic stenosis, where the left ventricle has to generate severely high pressures to get blood through a small orifice out into the systemic circulation. So high left ventricular pressures and this pattern in C, think about aortic stenosis. In B represents a underfilled left ventricle, and this is the classic mitral stenosis patient where you have LV volume underloaded. And then the regurgitant lesions give you a volume overload of the ventricle. In the case of mitral regurgitation is represented in D. This gives you a volume overload of the LV plus lower systolic pressures in the LV. Notice the peak up here of LV systolic pressure. The reason being is as the LV contracts, it doesn't have to eject out into the systemic circulation all the blood. In fact, it has a low pressure pop off into the atrium through the mitral valve that is regurgitant. And so think of the height of this LV pressure being lowered as compared to aortic regurgitation, which is also a large dilated heart, volume overloaded heart, and it gives us some of the biggest hearts you can get. And notice when the aortic valve normally closes, there should be a straight drop as you have isovolumetric relaxation. In the case of AI, you have continued filling and it slopes in because the aortic valve is regurgitant. Let's look at some very, very basic management points with regards to valvular heart lesions, and start with the aortic stenosis. In the case of aortic stenosis, you have a patient with a non-compliant ventricle that's thick, usually hypertrophied. You need to maintain the preload to that ventricle so that it will contract and generate an adequate cardiac output and pressure through that small orifice aortic valve. And when the aortic valve orifice is less than approximately 0.7 or 0.8 centimeters squared, we talk about critical aortic stenosis, because no matter what the pressure you generate in the left ventricle, you can't get any more flow across that teeny little orifice. We need to maintain afterload, very important, because if afterload drops, you cannot keep blood flow adequately filling that dilated systemic vasculature, and blood pressure will drop. And as blood pressure drops, coronary perfusion drops, and that big thick left ventricle, especially the subendocardium, is at risk for ischemia, independent of whether there's coronary artery disease or not, because it's so thick and using so much oxygen, and you can get into real trouble. So maintaining afterload, for example, with phenylephrine during induction, keep them in sinus rhythm. They need the atrial kick to fill that stiff left ventricle. And if the patient becomes hemodynamically unstable and goes into some rhythm like, let's say, AFib, SVT, they need that atrial kick very much, and you should cardiovert them immediately. If their blood pressure is going down and they are in sinus rhythm, keep the SVR up with a drug like phenylephrine. In the case of aortic insufficiency, you want to maintain a preload. You need the heart rate to maintain or slightly increased, and you definitely do not want afterload to go up. If that patient has an increase in afterload, more will go back through that insufficient aortic valve during diastole. So you want to keep them relatively full, mildly vasodilated, lower SVR, and relatively tachycardic. Mitral stenosis, the left atrium, the pulmonary system, as well as the right ventricle can see the effects of that mitral stenosis, and you have an underfilled left ventricle. You really want to avoid increases in pulmonary vascular resistance or drops in afterload. Like aortic stenosis, the blood is trying to get across that small orificed mitral valve, in this case, try to fill that left ventricle. And if you dilate the systemic circulation, you can't get very much more blood flow across that little orifice to fill the left ventricle, and you can get hypotension. So don't vasodilate them. Don't let them get hypoxic, hypercarbic, acidotic, or hypothermic, because already blood is backing up from that stenotic valve into the pulmonary circulation, potentially causing hypertension, pulmonary hypertension. And if you vasoconstrict the pulmonary vasculature with one of those bad things like hypoxia, hypercarbia, etc., you can have right heart failure. You need to give time for blood to cross that small orificed valve, so slow, and they definitely need the atrial kick. Keep them in sinus. In fact, if you develop acute AFib in a patient with mitral stenosis, they may be severely hypotensive, and if they are, cardioversion is indicated. Otherwise, rate control may be important, and pulmonary hypertension and right heart failure are often associated. Tricuspid valve. Tricuspid regurgitation is present in most of us, but it's a small amount and not a problem. But the most common cause of tricuspid regurgitation is probably left-sided failure with pressure backing up on the pulmonary circulation, pressure building up in the right heart, and then TR worsening. So right heart failure as a consequence of left heart failure. TR can occur secondary to pulmonary hypertension, destruction from endocarditis, such as IV drug use and bacteria coming through the venous system, seeding the tricuspid valve and destroying it, and also carcinoid tumors that produce serotonin. Serotonin, in the case of severe carcinoid, can cause problems with the right-sided heart valve, specifically the tricuspid valve mainly, but also the pulmonic valve. And you will tend to get tricuspid regurgitation as that tricuspid valve thickens and retracts, and you can also get pulmonic stenosis. We can decrease TR by decreasing pulmonary vascular resistance, giving oxygen, hyperventilating the patient, treating acidosis if it's present, and warming the patient if they're hypothermic. Which of the following medications is most likely to be beneficial in the medical management of a patient with acute mitral regurgitation prior to mitral valve replacement or repair? So clinically, this might be the patient with acute infarction, myocardial infarction, who infarcts a papillary muscle and gets acute mitral regurgitation with blood going backwards into the atria, which isn't used to it. The pressure builds up dramatically, and the pulmonary system sees that pressure, and it's not used to it, and you can get acute pulmonary edema. Well, you don't want vascular resistance to go up, or MR will increase, so norepinephrine's not a great choice. You don't want them slow, so metoprolol would be a bad choice. Phenylephrine would raise systemic vascular resistance also, and a vasodilator. Nitroprusside classically is one that could drop SVR, reduce MR until you can get the patient to the operating room to repair or replace the valve. So in MR, we want afterload down. Nitroprusside, the vasodilator, could do that. We want them relatively tachycardic and sinus, if at all possible. And as mentioned, the treatment for acute MR medically is to drop the SVR, add inotropes like dobutamine as necessary, and even potentially place an intra-aortic balloon pump as you prepare them for surgical repair or replacement. So vasodilation and tachycardia for MR, that's the medical management. We're going to have single slides on IHSS, Tetralogy of Fallot, but simplistically, IHSS is a problem with outflow tract obstruction, especially if preload goes down, if afterload goes down, or contractility goes up. So you want a patient who's vasoconstricted, who's full, and reduced contractility, i.e. beta blockers, to reduce LV outflow tract obstruction. And if the blood pressure drops in a patient with IHSS, adjust their vascular resistance with, for example, neosynephrine, give volume, consider beta blockers to reduce contractility. Tetralogy of Fallot. One of the components of Tetralogy of Fallot is a VSD, and SVR and PVR determine whether it's a left to right or a right to left shunt. Tetralogy of Fallot, when blood flow goes right to left, that is a cyanotic lesion, and right to left flow across a VSD would be increased if you vasodilated a patient. So dropping SVR, dropping pressures on the left side of the heart, can make blood go right to left and increase cyanosis. So in Tetralogy of Fallot, you want to keep them vasoconstricted. Neosynephrine is one of the treatments for a TET spell. And ketamine is a drug that has some specific benefits in patients with tetralogy of maintaining afterload. And in congenital heart disease patients, ketamine may be used even to induce general anesthesia in patients with tetralogy. Or intramuscular ketamine is used sometimes. And in tamponade, we want them full, as we mentioned. We want to maintain their contractility and keep them in sinus if possible. Next topic is mitral valve prolapse. The picture at the top shows initially a normal closed mitral valve with chordae tendineae and papillary muscles attached to the left ventricular wall. There's a posterior medial and anterolateral papillary muscles. anteriorly supplied by 2 coronaries, posterior by 1 coronary. Posterior is the one that often will disrupt in cases of ruptured papillary muscle. But in the case of mitral valve prolapse, you have, in this case, intact papillary muscles, intact chordae, but prolapsing of the mitral valve leaflet up into the left atrium, billowing, possibly a redundant mitral valve in this case, and mitral regurgitation may or may not be associated with that prolapsing. Anything that increases LV emptying can increase the amount of mitral valve prolapse and likely mitral regurgitation. So a drop in systemic vascular resistance, assumption of an upright posture, sympathetic stimulation, spinal anesthesia, hypovolemia, all can make mitral valve prolapse worse. And you may even notice a V wave if you happen to have a pulmonary artery catheter in and they develop severe mitral prolapse with mitral regurgitation. If a patient is having problems with prolapse and mitral regurgitation, replace their fluid and blood loss when it occurs, because you don't want an empty left ventricle. Minimize sympathetic stimulation. Treat their cardiac dysrhythmias if they occur, and think about treating hypotension with alpha agonists, vasoconstrictors, rather than with ephedrine. Which one of the following would be the most appropriate management goal of a patient with hypertrophic cardiomyopathy? Would it be to keep the LVEDP low, LVEDV low, volume in the left ventricle, pressure in the left ventricle, get the heart rate fast, reduce the heart contractility, decrease the systolic blood pressure? And the answer is, in the case of hypertrophic cardiomyopathy, you want the patient to have reduced cardiac contractility, beta blockers for example, maintain systemic vascular resistance, and keep their LVEDV, their volume in their left ventricle, up. So let's look at that next. The picture at the top right shows hypertrophic cardiomyopathy without obstruction first, and notice the thickening of the septum. In the case of this patient with hypertrophic cardiomyopathy who comes to the operating room and let's say they hemorrhage, they become hypovolemic for whatever reason, and the LV empties, maybe because of that hypovolemia or increased contractility or a reduction in SVR as you turn up 2 MAC of an inhaled agent, you can see how LV outflow tract obstruction can occur. The mitral valve leaflet here, the anterior leaflet can get pulled into the LV outflow tract and sucked out into it and cause an obstruction. That's called systolic anterior motion of the mitral valve leaflet. And as it obstructs the LV outflow tract, it also doesn't coapt normally with the posterior leaflet, and you get severe MR also. So our goal for a patient with this thickened interventricular septum with hypertrophic cardiomyopathy physiology is to keep the chamber size large and reduce contractility. Beta blockers will do that. Keep the preload up, giving volume. Phenylephrine not only vasoconstricts systemic vascular resistance but constricts the venous capacitance vessels and increases filling of the ventricle, and maintain afterload. So acute hypotension in a patient with hypertrophic cardiomyopathy, phenylephrine, volume, possibly beta blockers. Next topic is PFO, or patent foramen ovale diagnosis. Clinical example would be someone who has episodes of transient ischemic attacks or possibly paradoxical embolization if you believe it is coming from the right side, crossing over to the left side, and then causing the TIA. So paradoxical embolization could be the clinical cause of a transient ischemic attack. If a patient is in the ICU, I've taken care of patients and diagnosed this before, where post-cardiac surgery, a patient had a very low PaO2 despite increasing FiO2. Lungs seemed to be okay. FiO2 went from 60 to 80 to 100% with little change in P to AO2. That is evidence of a shunt. And when I did an echo, there was a large right to left shunt across the interatrial septum. Now, the picture at the right shows a interatrial septum bowing from the left side over towards the right side. And when you inject agitated saline, which is called a contrast bubble study. You can take 10 cc syringes with a stopcock in between and inject fluids back and forth between these through the stopcock, and you'll see the 10 cc syringe fluid within it, the saline, look kind of cloudy, and then inject it through a central line or a peripheral IV that's running fast. And these contrast bubbles show up in the SVC, then in the right atrium, and in some cases they just show up in the right atrium and never cross over into the other side. That would be a normal bubble study. But you may have to elicit conditions that put a patient at risk for opening up a PFO, and Valsalva is one of those. When you Valsalva, you expire against a forced expiration, that is, against a closed glottis. So you're raising intrathoracic pressure. As you raise intrathoracic pressure and hold a Valsalva, venous return goes down to the right side. As venous return to the heart goes down, the right atrial pressures drop. You inject the agitated saline, release the Valsalva, and as you release the Valsalva, the intrathoracic pressure drops, blood flow increases dramatically to the right side, and temporarily the right-sided pressures exceed the left-sided atrial pressures. And if there's a PFO, these little bubbles will cross over, and you will see them on the left atrial side. SB antibiotic prophylaxis. Bacterial endocarditis prophylaxis has changed over the years, and currently it's much easier to remember that we need to prophylax the highest risk patients when you have dirty surgery, such as the patients that are at risk are those with prosthetic cardiac valves, those who have had endocarditis before because they obviously have something going on in their heart that's putting them at risk, and those with congenital heart disease, specifically who have foreign material in their heart, like shunts and conduits, and if they've had something closed with, for example, Gore-Tex, and it hasn't had a chance to endothelialize over time, usually less than 6 months, this would put a patient at risk, highest risk for endocarditis. And then cardiac transplant patients who develop cardiac valve problems also. Those are the highest risk patients where we really need to think about SBE prophylaxis. And when you have those conditions and you undergo dental procedures that manipulate gingival tissue where bacteria can seed into the blood, periapical regions of teeth, or perforate the oral mucosa, antibiotics should be given. In invasive procedures where there's incision or biopsy on the respiratory tract or infected skin or musculoskeletal tissue, then you should also think about giving antibiotics. It's not recommended for just like straightforward bronchoscopy or cystoscopy. And an important point about antibiotics, usually we think of penicillins first and cephalosporins, and what do we do with a patient who's penicillin allergic is a current hot topic, and most agree that if you have a history of anaphylaxis with penicillins, it's not a wise idea to use a cephalosporin, and you would avoid that and use a different antibiotic. While if someone has a history of simple rash to penicillin in the past, most will go ahead and use the cephalosporin if that was the next drug, or the drug that's indicated for prophylaxis, that is. PDA, or patent ductus arteriosus, is the next topic, often present in premature infants. We can close it pharmacologically occasionally by giving prostaglandin inhibitors like indomethacin. We will talk a little bit later about keeping it open, which can be done with prostaglandin infusions. So by blocking prostaglandins with indomethacin, you can close a ductus in some patients. A PDA is shown in the graphic on the right. It is a communication between the aorta, often at the left subclavian or peri-left subclavian area, connecting the aorta to the main PA. And blood flow can go left to right, right to left, bidirectional, depending upon SVR-PVR balances. Normally we think of it as going from the aorta to the pulmonary artery because the pressure is higher in the aorta. But if for some reason pulmonary vascular resistance went up dramatically, in an operating room, for example, when a patient becomes hypoxic, hypercarbic, cold, acidotic, it could reverse, and you could have a huge shunt across the ductus. And instead of a left to right shunt, which is a quotes pink shunt, this would be then a right to left shunt, which could be a cyanotic. And so intraoperative sudden drop in saturation, unresponsive to oxygen, and not a problem with the tube or position of the tube or the lungs. Think this could be a ductus that opened back up from the usual transitional circulation. It is necessary for survival to have a patent ductus in certain patients, and one of those is hypoplastic left heart syndrome, HLHS, where the ductus is kept open usually by IV prostaglandins to keep the patient alive while they're optimized for surgery, which is usually a 3-stage surgery, Norwood procedure, and there's multiple variations of ways to repair hypoplastic left heart. Some people transplant hypoplastic left heart. If you clamp the PDA, for example, up in the neonatal intensive care, you're going up to provide anesthesia for a PDA ligation. It's usually done through a teeny little thoracotomy on an often premature infant who's intubated usually, and it's usually a very simple procedure because a clamp, a tie, something is put on the PDA and closes off blood flow, and the low pressure runoff that was previously available into the pulmonary system is gone, and oftentimes you will see before tie-off a blood pressure of, let's say, 60/25, a wide pulse pressure because of that low resistant circuit of the pulmonary system and left to right shunt. And as you tie it off and no longer let blood go from the aorta into the pulmonary artery in that low pressure diastolic runoff, the diastolic pressure bounces up and you'll have 60/40, for example. There are other complications of PDA ligation, such as bleeding. You can tear these vessels. Recurrent laryngeal nerve injury with vocal cord paralysis is another one. Another lesion is tetralogy of Fallot. And tetralogy of Fallot implies 4 lesions, and they're shown here. One is a narrowing of the pulmonic valve or outflow tract. 2 is thickening of the right ventricle as it's trying to pump against the obstruction to the lung. 3 is the displacement of the aorta, so it's called an overriding aorta over the septum. Here's the septum, it's riding over top of it instead of being directed towards the apical area of the left ventricle. And a ventricular septal defect opening between the left and right ventricles. Now, this patient can have right to left shunting across this lesion, or left to right shunting. And a hypercyanotic spell, or TET spell, is a patient with tetralogy of Fallot who suddenly has a decrease in SpO2, and this can result from a decrease in SVR, whatever causes it. For example, if you turned on nitroprusside to a patient like this, or if you turned on high concentrations of inhaled volatile anesthetics, could do it. If you increase the pulmonary vascular resistance, a crying, screaming, sympathetically stimulated child could have pulmonary vascular resistance go up and more blood be shunted from the right side to the left side. So a TET spell, sudden drop in SpO2 in that screaming, crying kid, or in someone in which the SVR has decreased who has tetralogy of Fallot, we treat it with neosynephrine to raise the systemic vascular resistance and reduce the right to left shunt, and fluids, but the most important thing to do is increase the SVR. Beta blockers are occasionally used after neosynephrine and volume, and we want to avoid factors associated with increased PVR, and that is crying, cold, acidotic, hypercarbic, hypoxic kids. Ketamine has some advantages in anesthetizing tetralogy of Fallot patients because of maintenance of SVR. A couple miscellaneous congenital heart disease lesions that very important to know because some of the things that we do in the preoperative period can negatively impact them if we don't understand the physiology. And the first one is a Fontan procedure and Fontan physiology. Now, the Fontan procedure is often the last procedure in the management of a patient with a single ventricle. They often go through a modified Blalock-Taussig shunt, i.e. a 3.5 to 4 millimeter Gore-Tex tube graft, teeny little one, going between the subclavian and the pulmonary artery. They grow a little bit, then a Glenn SVC to pulmonary artery, and then a Fontan, the right atrium, to the main pulmonary artery. And basically what this is doing is setting up a patient who has only one ventricle, so that one ventricle then, in the top graphic here, pumps to the systemic circulation, while there is no ventricle on the other side, and in this case blood comes from the SVC and IVC into the main pulmonary artery, not driven by ventricular contraction. So no right ventricle, pulmonary blood flow becomes dependent upon CVP, and you could see that in Fontan physiology, that if a patient became hypovolemic, dehydrated, low CVP, CVP is the driving force for blood to go into the lung, and you could have really bad problems with pulmonary blood flow. So you don't want to do anything that raises pulmonary vascular resistance, the hypoxia, hypercarbia, hypothermia, etc., or a low CVP, which will reduce pulmonary blood flow. The next lesion is hypoplastic left heart syndrome. And in this patient, we must keep the interatrial communication and PDA open, and these patients will be on IV prostaglandins taken care of usually by specialists in this area of anesthesia, and an HLHS patient physiology is shown on the bottom right, in which you can see the left heart has not developed well, and often the aorta is associated with it, so you have a hypoplastic aorta, hypoplastic left ventricle, one ventricle here, and you can see that the coronary arteries are dependent upon blood flow going out the PA here through a ductus, retrograde down the aorta through the coronary arteries, and anything that potentially reduces blood flow down those coronary arteries is going to reduce myocardial blood flow, and the single ventricle may fail. So let's look at some things that are important related to hypoplastic left heart. One, we must balance SVR and PVR. Why? Look what would happen if you dropped SVR. If SVR went down, blood flow would come out the ventricle, up the main PA, and would go to the systemic circulation preferably, rather than to the pulmonary circulation. And so you'd get lots of flow going systemically, not as much flow going to the pulmonary artery, and you may have desaturation. As opposed to if you drop pulmonary vascular resistance, i.e. with supplemental oxygen, hyperventilation of a patient, which are not good things to do in this physiology. If you hyperventilated down to CO2s, let's say in the 30s, and gave supplemental oxygen, they dilate the pulmonary vascular resistance, blood goes into the pulmonary artery, your sats look great, SpO2s in the high 90s, and you think you're doing great until you get your blood gas back, and it shows a severe acidosis because blood is not going as much systemically. So we must balance PVR and SVR. We do not hyperoxygenate or hyperventilate, and in fact we often use subatmospheric FiO2 like 18%, and keep the PaO2s in the 50s and the PCO2s in the high 40s or low 50s, and they undergo a staged procedure or transplant. PGE1 in congenital heart disease is another keyword topic, or prostaglandins. Remember, prostaglandins can keep the ductus open, and there are lesions called ductal dependent lesions in which you want to keep the ductus open. HLHS, hypoplastic left heart, we just talked about. Coarctation of the aorta, transposition of the great arteries, those are examples where we want to keep the PDA open. If the PDA closes in a patient with HLHS, there can be rapid deterioration, acidosis, and cardiac arrest and death. Antithrombin III deficiency. Antithrombin III is necessary for heparin to have its effect. Heparin binds to antithrombin III, and accelerates its normal action. If you have a deficiency, it can be due to congenital or acquired means. Congenital, usually homozygous patients die in infancy, while heterozygotes have thrombotic events. So a defect in antithrombin III, heterozygous, they can have thrombotic events. If it's acquired, for example, you have a patient who's on long-standing days of heparin infusions. Maybe they have coronary disease, they've gone to the cath lab, they've been on heparin infusions for a long period of time. They finally come to the heart room for their coronary bypass surgery, and you go and try to get them systemically heparinized prior to bypass. They may not respond to heparin the way that other patients do because they've consumed antithrombin III. And if that happens, that's called heparin resistance. And after we've given relatively high doses, somewhere usually between 600 to 800 units per kilogram or 6 to 8 milligrams per kilogram of heparin, usually we express it in units, 600 to 800 units per kilogram of heparin, and they still have an ACT less than 400, you should really be thinking about antithrombin III deficiency. And you can replace antithrombin III with FFP. There are concentrates, recombinant antithrombin III, that you can use to replace it. Remember, heparin has to bind to this to have its action. Heparin potentiates the action of antithrombin III, which then binds to thrombin and other coagulation factors, inhibiting them. So that's the mechanism of heparin's action, is via antithrombin III. Protamine is what we use to reverse heparin. Protamine is a polycationic, positively charged molecule, as opposed to heparin, which is a anionic, negatively charged molecule. So we have an electrostatic interaction when we administer protamine to a patient on heparin, and quickly protamine and heparin form a complex, reversing the heparin effects. Now, there's problems with protamine, and if protamine is given rapidly, you can have hypotension because of arterial dilation and venous capacitance, dilation of the venous capacitance vessels, and you will see low MAP, low filling pressures. When you look on echo, both the left ventricle and right ventricle will be small, preloads down. Really, all you need to do is just don't give your protamine so fast. Give some volume, give a vasoconstrictor like phenylephrine or calcium. Rarely do you have to add an ionotrope. If you administer protamine slowly, and often with calcium or phenylephrine, these are ways to try to avoid the decrease in systemic vascular resistance and the decrease in venous capacitance that can occur with protamine administration. Now, there's a really bad thing that can happen with protamine administration, which is catastrophic pulmonary hypertension. And rarely does this occur. I've seen it maybe 4 or 5 times in the last nearly 30 years. And what happens is you can get an anaphylactic or anaphylactoid reaction to protamine, in which the pulmonary artery constricts greatly. If the pulmonary artery constricts, the right ventricle has to pump against this increased resistance, and it dilates and fails, while the left ventricle doesn't get much volume and is very small. So what you will see is severe hypotension, elevation in CVP as the right heart pressures go up, pulmonary artery pressures are going up, and the right ventricle on echo looks big and failing, while the left ventricle is banging away and very small. So it's RV dysfunction, big old dilated right ventricle. Stop the protamine. Epinephrine can sometimes get you by. Many times you have to reheparinize, go back on bypass, and sometimes even come off bypass without using protamine after you have gone back on for a period of time to allow the RV to recover. The next topic is HIT, or heparin-induced thrombocytopenia. Unfractionated heparin is given during bypass to prolong ACTs, usually up into the 480 or so second range or more. And when you are exposed to unfractionated heparin during bypass, a large number of patients, 25 to 50% of them, will seroconvert, meaning that they see the heparin, their body sees the heparin and says, aha, this is foreign material, I'm going to produce some antibodies, and they will produce those antibodies. Now, if they just produce antibodies, but those antibodies don't do anything to the platelets, you call that a seroconversion without HIT. But if they get antibodies and those platelet factor 4 reactive HIT antibodies are present and drop the platelet number greater than 50% decrease, and this occurs in about 1 to 3% of patients, that is called heparin-induced thrombocytopenia. You need to stop all heparin, including heparin that could be in flushes, in CVP, PA catheters, arterial lines. Stop all the heparin, and if that's all you did, these patients have platelets that are basically white clots forming in the body. These platelets are aggregating, and you're going to get thrombosis in 25 to 50% of them. So not only do you have to stop the heparin, but usually start a DTI or direct thrombin inhibitor. And an example of that would be argatroban, bivalirudin. Don't give platelet transfusions, and don't start warfarin until thrombocytopenia has resolved. So not only do you need to stop the heparin, but you need to anticoagulate. Management during bypass in a patient with previous HIT. If they have previous HIT that has resolved, you can use heparin because this is not a classic antigen-antibody anamnestic response where your body says, I remember that, and can rapidly produce antibodies again when they're exposed the second time. So previous HIT, where there's no measurable antibodies, platelets are okay, you can use heparin again. Now, if it's subacute HIT or acute HIT, where they have the antibodies, plus or minus thrombocytopenia, there's many other options for anticoagulating patients. We're going to avoid heparin, often use a direct thrombin inhibitor rather than the indirect thrombin inhibitor, heparin, which has to work through antithrombin III. And the direct thrombin inhibitors are drugs like bivalirudin, argatroban, lepirudin. And there's other drugs that can be used to inhibit platelet function in the perioperative period and the pericardiopulmonary bypass period. Next question is, an arterial blood gas taken from a patient whose temperature is 34 degrees centigrade is reported as pH 7.32, PaO2 56, and PaCO2 of 44. If the arterial blood gas was corrected for the patient's temperature, which is 34 degrees, they're hypothermic, which of the following would be true? PaCO2 would be higher with hypothermia, PaO2 would be higher, pH would be higher, or there'd be no change in pH, PCO2, or PaO2. And the answer is that PaCO2 would be lower, PaO2 would be lower, and the pH would actually be higher, looking like a respiratory alkalosis because the PCO2 would be lower. So let's look at this concept of temperature correction of arterial blood gases and the effect of hypothermia on arterial blood gases. This graphic is from a chapter I wrote in Miller's Atlas of Clinical Anesthesia, and it's attempting to show the effect of temperature on arterial blood gases. And you can see that when the temperature goes down, hypothermia, the kinetic energy of the molecules of carbon dioxide and oxygen are decreased. And it's the kinetic energy, those molecules bouncing against the side, creating a partial pressure that we measure when we measure arterial blood gas. And so if they are colder, have less energy, bouncing less against the walls, creating less partial pressure, with cold, the PaCO2 and the PaO2 go down. As the temperature goes up, converse occurs. They have more kinetic energy, and PaCO2 and PaO2 partial pressures will go up. Now, the interesting thing with hypothermia is that as the oxygen and CO2 goes down, the CO2 goes down and the pH then changes because of that respiratory-like alkalosis. And in fact, when you get down in temperatures of the 25, 28 degrees that are sometimes used during cardiopulmonary bypass, you can see very high pHs up to like 7.6 or so, and CO2s that are very low. So temperature correction, CO2 and oxygen partial pressures decrease with hypothermia. The next topic is one that is somewhat difficult to understand. These are two graphics from, again, the chapter in Miller's Atlas of Clinical Anesthesia that I wrote in an attempt to explain alpha-stat and pH-stat blood gas management. There's only a couple points that I want to make. One is that this concept of what do we do with blood gases when we have a temperature that is cold is one that has been debated for some time. And the reason why is because when someone is on cardiopulmonary bypass, for example, at 28 degrees, you draw their blood from them, and the blood is 28 degrees, and you put it in a blood gas machine. The blood gas machine warms it standardly to 37 degrees and reports a blood gas based upon what it would be if the temperature was 37 degrees. But the patient's temperature itself is not 37 degrees, it's actually colder. And we already know that cold decreases the partial pressure of CO2 and decreases the partial pressure of oxygen. And so in the case of alpha-stat, our goal is to have a temperature uncorrected. That is, I don't care what the patient's temperature is, what comes out of this machine is a pH of 7.4 and a PCO2 of 40 optimally. As opposed to the pH stat, where you say, you know what, the patient's temperature is 28 and I need to make some corrections. So you temperature corrected, correcting to the patient's temperature of real 28 degrees, we know that the correction will result in a drop in CO2. It's not going to be 40 because that's 40 at 37 degrees. At 28 degrees, it's about 26 millimeters of mercury, lower partial pressure. And if the CO2 is lower, the pH is higher, apparent respiratory alkalosis, so it looks like you have a very high pH. And so you say, aha, CO2 is too low. I need to add CO2 to the circuit. And pH stat may add CO2 to the circuit or lower the sweep rate, which is the liters per minute going past the oxygenator of a cardiopulmonary bypass system. And this is getting more complicated than I want to get at this point, and so I want you to understand that alpha stat and pH stat are two different ways to manage blood gases in a hypothermic patient. Okay, in the pH stat we want to get the temperature corrected back to a normal, quotes, state. So you have to add CO2 to some of those patients. So comparing alpha stat and pH stat, if there's normal thermia, there's no difference. It's only under hypothermic conditions that we're thinking, should we do one or the other? And if you have more CO2 in a patient, as you would in a pH stat, your cerebral blood flow is going to be higher, and that initially sounds good, except that autoregulation of the head is impaired, and you may actually deliver more emboli to the head that's getting luxuriant blood flow, because there's always little microemboli in this cardiopulmonary bypass circuit that gets into the patient and comes from the patient and circulates around and can go up to the head, especially if it's vasodilating. In adults, we usually use alpha stat, and in pediatrics, also alpha stat, although there are some variations. If you want to cool a patient's brain more rapidly, there may be some benefit to pH stat because the CO2 is higher and delivers more blood flow to the head. And there's some controversies out of outcomes, and we will not go into those at this time. Next question is, a 45-year-old male with preserved LV function is undergoing bypass. Just after separation from bypass, the blood pressure is low at 65/40, the pulmonary artery pressure is high at 50/30, the CVP is high at 20, and the cardiac index is only 1.6, heart rate's 85, and sinus rhythm. What's the most appropriate immediate therapy? Well, this is a severely hypotensive, filled, stretched ventricle with a low output, and in this case, you want to go back on bypass and reassess and think about other ways to come off, maybe with inotropes and possibly assistance mechanically. So let's look at least one algorithm for separation from cardiopulmonary bypass. And again, this is from Atlas of Clinical Anesthesia, chapter I wrote. And the first thing that you should do is to optimize your electrolytes, your acid base, make sure your hemoglobin's okay, make sure you turn on your ventilator, which I have forgot to do in the first minute after bypass in my life. And if you don't go through a checklist, you probably will forget some of these things at some point also. Make sure the patient is warm, you're adequately anesthetized, the cardiac function looks okay. And one of the first things you can do is say, what's the heart rate? Okay, if it's high, maybe they're hot or they're awake or semi-awake and they need to be anesthetized appropriately. If their heart rate is low, which is more common, you may have to pace the patient temporarily or use drugs to increase their heart rate, but pacemaker, epicardial is commonly used. Look at the rhythm. Is the rhythm sinus? If it's not, can I get that patient in sinus by some means? Do they have a electrolyte abnormality, residual hyperkalemia from cardioplegia, for example? And once your heart rate and rhythm and all those other things have been optimized, you separate from bypass, and one of the first things that you look at is their mean arterial pressure. And if that's a great mean arterial pressure and their preload looks good and their contractility looks good, you just keep constantly reassessing the heart rate, rhythm, contractility, and pressure, and hopefully none of these change dramatically and you are good to go and the patient does well. But what if you separate from bypass and they have a very low blood pressure? One of the first things you need to do is make sure that the pump is primed adequately, that is, the preload is adequate. So how do you assess preload? You can assess that with echocardiography. You can assess it visually. You're seeing the right ventricle in your field when the chest is open. And you can measure cardiac index if you have a PA catheter and look at your SVO2 if you have a mixed venous oxygen catheter. It will give you ideas of how good your cardiac output is, and you can look at contractility on TE also. If the contractility is low and your preload is adequate, then you got to say, well, if the heart's filled adequately but the heart's not beating strongly, I better add a beta agonist, epinephrine, for example, a phosphodiesterase inhibitor like milrinone, or potentially put a balloon pump in. If contractility is normal but blood pressure is low, then you need to think, okay, maybe the blood pressure is low because they're just vasodilated. And if they're vasodilated, you may need to add a vasoconstrictor like phenylephrine, norepinephrine, vasopressin, and in severe vasoplegia, you can bind nitric oxide with methylene blue. And if the afterload is high, we may have to use vasodilators or milrinone, but that usually would not contribute to a low blood pressure. And then look at the pulmonary vascular resistance, and if it's high, you may have to give a drug that decreases the pulmonary vascular resistance like milrinone, inhaled nitric oxide. And hopefully you've been able to normalize the blood pressure at that point, normalize your preload, contractility, and afterload, and continuously assess these. If cardiovascular collapse occurs despite all of these, you may need to resume cardiopulmonary bypass and consider balloon pumps or ventricular assist devices. But one of the take-home messages is that if you come off bypass, the blood pressure is low and the filling pressures are high and the index is low. That is a stretched ventricle. It's failing. Don't allow it to stretch more and get damaged. Immediately go back on bypass and reassess. Milrinone is the next topic, the drug. It increases intracellular cyclic AMP by inhibiting its breakdown. It is a phosphodiesterase 3 inhibitor, and in the graphic on the top right, it shows phosphodiesterase, PDE3 here, and cyclic AMP. Cyclic AMP is increased via beta agonists, via beta receptors, epinorepinephrine, G proteins, increase formation of cyclic AMP, which results in increased cardiac contraction. And if you add on to that catecholamine or alone and inhibit phosphodiesterase, you inhibit the breakdown of cyclic AMP, so you get even more contraction. So milrinone occasionally is given alone, inhibits phosphodiesterase, inhibits the breakdown of cyclic AMP, are given often in combination with a drug like norepinephrine or epinephrine to synergistically increase contraction by increasing cyclic AMP. And it causes inotropy, contraction, lusitropy, relaxation, but it's also a vasodilator of both the systemic and pulmonary vascular system. When you bolus milrinone, you often will get a drop in blood pressure. One of the gaps in knowledge that occurred several years ago was the thought that if you have a patient who develops right heart failure who is hypotensive, should you give them milrinone or not? Many people thought it was a great choice, and it's not, because if someone has right heart failure, you're thinking, oh, milrinone will help that, drop the pulmonary vascular resistance, help right heart function. but it also is a vasodilator. And if they're already hypotensive, that's not a great first-line choice. Now, there's a lot of inotropes and vasopressors, and I just want to briefly touch on a couple major points as we finish up here. Up at the top right is a summary of myocyte physiology and sites of inotropic action. Beta agonists work through beta receptors, G proteins, adenylate cyclase, increasing cyclic AMP. Glucagon can actually be used to reverse beta blocker toxicity because it works also by increasing cyclic AMP, but by a different mechanism. And then you have the PD inhibitors, the phosphodiesterase inhibitors, which inhibit the breakdown of cyclic AMP. And the final mechanism is one of calcium-mediated effects in the heart. Dopamine isn't used very often anymore, but at varying doses can have varying effects from dopaminergic, increasing mesenteric and renal blood flow, increasing cardiac contractility, beta effects, and alpha effects at higher ends of dosing. Although this dosing range of 5 to 20, a patient who's on low-dose dopamine may get a tachycardia, where you would think, hey, that's just a dopaminergic level. So it's a crossover and wide variation in response to dopamine. And we don't use dopamine for, quotes, renal preservation in the normal patients at risk anymore. Epinephrine has beta-1, beta-2 effects, alpha-1, alpha-2 effects. It has causes vasoconstriction and increased contractility. And norepinephrine we usually give because of its alpha effects and vasoconstriction that it occurs. If you have someone with septic shock, for example, and you want to vasoconstrict them, norepinephrine is a good choice. Dobutamine, beta-1, beta-2 effects. It's going to have increased contractility through beta-1 and vasodilation through beta-2. So a patient with congestive heart failure, dobutamine may be one of your choices. Milrinone, cyclic AMP inhibition, increases myocardial contractility and vasodilates the systemic and pulmonary vasculature. And vasopressin through different mechanisms, V receptors, V1 receptors on the vasculature causes peripheral vasoconstriction. And one of the interesting things about vasopressin, it tends to cause an increase in systemic vascular resistance with less effects on the pulmonary vascular resistance. And so we often don't want to raise pulmonary vascular resistance, but we want to raise SVR, and vasopressin is one that we may use for that. Mechanisms of vasodilators. Nitroprusside and nitroglycerin are vasodilators. Nitroprusside and nitroglycerin work through cyclic GMP and nitric oxide to dilate arterioles, mainly for nitroprusside, and venules, mainly for nitroglycerin. Alpha blockers, there are non-selective and selective alpha blockers, and some of these drugs are used to prepare patients, for example, with pheochromocytoma, who you want to provide alpha blockade before surgery, and some are still used to manage hypertension. Phentolamine or regitine is reversible and is used to treat pheochromocytoma. That is a reversible block of the alpha receptor, while selective alpha blockers like telazoline, prazosin, minipress, and prazosin minipress was one of the commonly missed questions in 2015, or gap in knowledge that it's a selective alpha blocker. Vasoconstrictors, obviously phenylephrine, alpha-1 agonist, commonly used, and methoxamine, rarely used. Beta blockers in the perioperative period, what do we do with them? There's been a lot of controversy over this. The perioperative administration of oral extended-release metoprolol to beta blocker-naive patients in the POISE trial, a very famous trial, was associated with a decreased risk of heart problems like MI, but there was more stroke and an increased mortality, showing that, boy, giving metoprolol to someone who's not already on it, extended-release metoprolol, probably not a wise idea. American Heart Association, American College of Cardiology says that we should not abruptly withdraw beta blockers, that they should be continued in patients undergoing surgery who have already been on beta blockers, and that they can reduce perioperative cardiac events, but the benefit is offset in those beta blocker naive patients by a higher relative risk of stroke, bradycardia, and there's few studies to support the effectiveness of giving beta blockers preoperatively to reduce the risk of surgical death. I have no intention to review every step in the ACC/AHA new guidelines, but I do want to point out one thing, and that is a patient with a coronary stent, which is a gap in knowledge, 2015. If a coronary stent is placed in a patient, you should know whether it's a bare metal stent or a drug-eluting stent. If possible, if it's an elective surgery, you should delay surgery until after an optimal period. In bare metal stent, we usually think of at least 30 days, while a drug-eluting stent, a year for epithelialization. But wait a second, if they have a stent and you got to do the surgery, what should you do? So if you follow this down, they've had stent implementation, and it's an elective surgery, just delay it. If it's not elective surgery, continue your anticoagulation unless the risk of bleeding is greater than the risk of stent thrombosis. And you really should not take that patient with a drug-eluting stent who's had it recently placed and be doing surgery out in an ambulatory standalone center where you could not do any intervention, i.e. coronary intervention, if you had some problems. So the take-home message from coronary stents is know the difference between bare metal, 30 days, and drug-eluting stent, 365 a year, and that you can follow the ACC/AHA guidelines if they are somewhere in between those, like less days than that. Let's finish up now with some select cardiac drugs and just a couple other topics. Vasopressin is the first one. Vasopressin acts via V1 receptors, causing vasoconstriction systemically, and has a less effect on the pulmonary vascular resistance than does epi and norepi. And it's going to increase diastolic pressure during CPR, and that's one of the reasons vasopressin and epinephrine is given during CPR, because as you do chest compressions, if the diastolic pressure is higher, the coronaries are perfused better, the heart gets nutrients and may defibrillate easier and recover. Now, vasopressin has a longer half-life than does epinephrine, and you can give vasopressin and 20 minutes go by as you're doing CPR. Well, epinephrine you need to repeat every 3 to 5 minutes because catechol O-methyltransferase is chewing it up in the patient. And vasopressin tends to be more efficacious in the setting of acidosis than does the catecholamine epinephrine. Pressors and inotropes, receptor-mediated effects, mainly cyclic AMP. Norepinephrine works through alpha and beta 1, dopamine through alpha, beta, and dopaminergic, and dobutamine through both beta 1 and beta 2. Phosphodiesterase inhibition is milrinone, and when we talk about inodilators or inotropic agents that are also dilators, milrinone is one of the classic ones, dobutamine is another classic one, but often forget that low-dose epinephrine is an inotrope, and because of its beta-2 effect can act as an inodilator. But milrinone, dobutamine when you want inotropy and vasodilation. If all else fails, you give inotropes and a patient is not doing well ventricularly wise and you need to support the heart, and an intra-aortic balloon pump may be indicated. Intra-aortic balloon pump is placed in the descending thoracic aorta just below the takeoff of the left subclavian. You don't want to occlude the left subclavian or the coronary arteries, so you can use echocardiography to place it, and it inflates during diastole and improves coronary blood flow, and deflates during systole, improving ejection of the left ventricle. And LV failure, unstable angina, difficulty weaning from bypass, and acute mitral regurgitation, where its deflation during systole reduces pressures inside the left ventricle and reduces mitral regurgitation. There's some contraindications. One, if it's inflating during diastole and increasing the pressure in the ascending aorta and down the coronaries, if someone had aortic insufficiency that's moderate to severe, blood will go back through that aortic valve with inflation and dilate the left ventricle and worsen failure. So AI, moderate to severe, is a contraindication to intra-aortic balloon pump. And then if they have a really bad aorta like aneurysms or grafts, you're not going to want to shove something up through it, usually through the femoral artery. Although you can access the axillary artery to put a balloon pump also. What does a balloon pump do? It will decrease peak aortic systolic pressure as it deflates. It decreases oxygen use by the heart and decreases the wedge pressure. All good things. And increases the intra-aortic diastolic pressure. And remember, coronary perfusion pressure is diastolic blood pressure minus LVEDP. So if you're dropping LVEDP and increasing diastolic blood pressure, you're improving coronary blood flow, and you'll improve also cardiac index. Again, this is a picture from Atlas of Clinical Anesthesia showing balloon inflation in diastole, which here's the end of the T wave after the dicrotic notch. It augments diastolic blood pressure, in which diastolic blood pressure exceeds systolic blood pressure, and then deflates during systole, decreasing end diastolic pressure and improving outflow from the left ventricle. Pharmacology of inhaled nitric oxide. Up the graph at the top shows nitric oxide being inhaled into a lung, often at 20 parts per million or so, crossing over alveolar membrane, capillaries, increasing cyclic GMP-mediated relaxation of endothelial cell smooth muscle and vasodilation of the pulmonary vascular resistance. It selectively dilates the pulmonary vascular resistance. Selective, unlike nitroprusside or nitroglycerin, which also vasodilates the systemic vascular resistance. So pulmonary hypertension and RV failure are places where inhaled nitric oxide may be used. Cyclic GMP mediated, as previously mentioned. Why does it have a short half-life? Because as it crosses over and causes the vasodilation, the nitric oxide binds to hemoglobin and is immediately terminated in its effect, so it does not systemically vasodilate. There's some toxicity issues. It can be rapidly metabolized to methemoglobin, but we have lots of hemoglobin around, so it's usually not a problem with methemoglobinemia. And because it's excreted by the kidneys. It can inhibit platelet adhesion and aggregation, and you don't want to stop it suddenly. If you're on 20, 40 parts per million and you don't want to go to zero, but slowly wean down, and because you can get a rebound effect in pulmonary vascular resistance if you just stop it. The last slide of key topic words is miscellaneous cardiac, doxorubicin or erythromycin. If a patient has been on that in the past, worry about their cardiac function. They could have received these drugs because of treatment of leukemia or lymphomas. Cardiotoxicity can ensue months after initiation of therapy with heart failure, cardiomyopathy, low voltage QRS complexes, decreased ejection fraction, and the more they get of doxorubicin, the higher the chance of causing this heart failure. Acute toxicity begins early in the treatment with dysrhythmias and QT prolongation and heart failure, and often will reverse with discontinuation of therapy, while chronic toxicity results in LV dysfunction and cardiomyopathy. The last concept is renal failure and cardiopulmonary bypass. When you put patients on artificial circulation, cardiopulmonary bypass, if they have pre-existing renal insufficiency and they're older, their chance of having problems with renal failure postoperatively go up. So if they already have a creatinine of, let's say, 2, and they're 80 years old, and they have a ventricle that's not pumping well after heart surgery, so their kidneys aren't getting good blood flow after heart surgery, those are the classic ones that go into renal failure postoperatively. And pharmacologic protection with drugs like dopamine and phenoldiazepam have not been proven beneficial in preventing renal failure in these patients. This ends part 3 of 3, high-yield cardiac anesthesiology keyword review. Never stop learning, and good luck. This is a picture from Italy, and I had the opportunity to ride my bike there and climb the Dolomite Mountains for about 10 days this last summer. Have a good day.